Bismillahirrahmanirrahim. Hi everyone. I know it has been a while since the last video, but I'm hoping that I'm gonna resume some of these topics. And today I'm gonna start with what I think is an important topic: blood cultures. Is it fake news? So we're gonna talk about a case to demonstrate the importance of this topic, and then we're gonna talk about why this topic is important, and we're gonna talk about clinical scenarios when not to take blood cultures. And then we're going to talk about factors to take into consideration when you are examining the results of a blood culture, whether these results are true bacteremia or fake news. So let's start. So this is a case we have, and I think it's relatively common scenario. So we have a 38-year-old male with history of diabetes mellitus presented with left foot cellulitis. On admission, patient had fever of 38.2 and heart rate of 103. Other vital signs are okay. Examination showed a wide area of erythema and swelling in the dorsum of the left foot and distal shin with tenderness but intact skin. Ultrasound showed no underlying collections or gas. Blood cultures were taken and the patient was admitted for IV antibiotics. Next day, the patient's symptoms improved as well as skin redness and tenderness, and decision was made to discharge the patient with oral antibiotics for presumed non-purulent cellulitis. Just before discharge, though, blood cultures report came back with one aerobic bottle with gram-positive coxine clusters grew within 23 hours. Now, what should the hospitalist do? Should they cancel the discharge, repeat the blood cultures, maybe start IV antibiotics, or just consult ID? They're going to solve the problem for you. So think about it, and then we're going to talk about the next slide. So why do we think that this topic is important? Contaminated blood cultures target rates generally has been said to be about 2% to 3%. So most of the institutions or hospitals, they should have a contaminant rate of blood cultures in the institution, typically not exceeding 3%, but there is a wide range of reported rate ranging from 0.6 to up to 6%. But generally, it should be around 2 to 3%. Now, the issues of inappropriate interpretation of blood cultures are many, including, for example, patient harm from unnecessary antibiotic prescription. So if you assume that these blood cultures is true bacteremia, of course, it's a serious diagnosis. You want to start IV antibiotics. And, these antibiotics, of course, they come with side effects. Allergic reactions can happen. The patient may have diarrhea. Even worse, they can have Clostridium, Clostridioides difficile, or any other side effects of the antibiotic that you started unnecessarily if it's not a true bacteremia. Also, this will can potentially prolong the length of stay of the patient in the hospital. If the patient had a vascular catheter, and then with this bacteremia, most of the physicians, the standard of care is to remove, these vascular catheters. So whether they be for hemodialysis or any other use, or for chemotherapy, for example. So that might be unnecessary if the blood culture is contaminant and not a true bacteremia. Of course, all these actions have some financial burden, and that can be added to the cost of hospitalization. And then, of course, unnecessary consultation to infectious disease. This is, I believe, I'm not an ID specialist, but I believe this is probably one of the common reasons for consultations. And if you are working in an institution where there is a lot of load on the ID consults, then that might be a problem. But on the other hand, we all know that bacteremia is a serious disease, so you don't want to miss a serious diagnosis and potentially a life-threatening infection. So that's where the balance comes in, and that's why it's really important to make some effort to try to know whether these results are true or not. All right, so as we all know, prevention is better than cure. So I'm going to start with some of the clinical scenarios when actually blood cultures probably are commonly prescribed and ordered, but ideally they should not be. So, for example, per the IDSA, Infectious Disease Society of America, they do not recommend blood cultures to be taken in patients presenting with typical cellulitis. The yield is usually very low, reported to be less than 5%. Of course, some exceptions would be patient with high-risk features like patient with neutropenia or like necrotizing fasciitis, or patient in the ICU when they're really sick. You want to get consider blood cultures in these situations. But typical cellulitis, especially non-imperial cellulitis, uncomplicated patients, you don't really typically need to send for blood cultures. Community-acquired pneumonia, if the patient is not under the severe category, also the yield from blood cultures are low, and you don't want to prescribe or order blood cultures in these patients. Uncomplicated UTI, the same thing, and also patient who develop fever within 24 to 48 hours after surgery, because this is unlikely to be due to an infection. So an important part of this is really to try to think whether ordering blood cultures is indicated or not before getting into the trouble of interpreting the results. So generally speaking, there are 4 factors to consider when you examine the validity of blood culture results. These include, number 1 is the clinical feature of the patient and the risk factors associated with the patient, identity of the organism, and then number of positive sets or the number of positive bottles within a set. And then number 4 is the time of growth or time to positivity. So we're going to talk about these factors one by one. So let's start with the clinical features and risk factors. So things to consider is your patient has features of sepsis. Does the patient look really sick, or they're really looking like there's something going on with the potential diagnosis of bacteremia? How is the status of the immune system of the patient? Is the patient immunocompromised? Has any other risk factors for low immunity? Is there any other foreign body to consider? If the patient had a pacemaker, this patient had a prosthetic valve or a prosthetic joint. So all these factors are important. So for example, patient with mucosal barrier injuries, for example, patient who had cancer chemotherapy, patient who had surgical procedures lately, or patient who had GI pathology like mucositis that can potentially break the mucous membrane barrier. These patients have high risk to get a true infection of one of the common bacteria that's thought to be contaminant, which is Staph epidermidis. So if the patient has Staph epidermidis in the blood, usually in a healthy individual, most not, if the patient doesn't look septic, it's probably not a true bacteremia. But in some patients who have some high risk factors like these patients, you need to consider the possibility of a true bacteremia, even if the organism is a Staph epidermidis. Another example is patient with Corynebacterium, another bacteria that's thought to be a contaminant, maybe number 2 after Staph epidermidis. They still can cause clinically significant infections in the presence of medical devices like patient with joint prosthetics, patient with catheters, IV catheters, ports, vascular graft, prosthetic heart valve, or pacemakers, or other devices. So this patient, you need to be more careful in interpreting the results of blood cultures before you consider them contaminant. The second factor is the identity of the organism, the type of the organism. So some organisms are known to be associated with contaminant blood cultures, and other organisms should be considered as true bacteremia until proven otherwise. So for example, Staph aureus, almost always considered true bacteremia because it's a serious infection, can be associated with serious outcome. So Staph aureus is true bacteremia until proven otherwise. Other organisms include Strep pneumoniae, Strep biogenes, Strep galactiae, E. coli as well, and other Enterobacteriaceae, including Pseudomonas aeruginosa, Listeria also as well, Neisseria, H. influenzae, Bacteroides fragilis, important cause of anaerobic infections, Campylobacter species, and also other fungal and protozoal infection like Cryptococcus neoformis and Candida albicans. On the other hand, some of the common organisms that's usually identified as contaminant, the top one is probably the coagulase negative Staphylococcus aureus, Staph epidermidis, Staph capitis, Staph hominis, and Staph capreae. So this is probably the most common that you're going to encounter in clinical practice. Corynebacterium as well, Bacillus species, and Propionibacterium acnes, Micrococcus species, Verdens group, Streptococci, Lactobacillus species as well. So as you can tell, these are common organisms that can cause or be a result of contaminant blood culture result. But again, you have to take into consideration the clinical scenario of the patient, the risk factors associated with the patient. So these bacteria usually are not the organism that can cause contaminant and are not usually reported like this. So initially they might be reported as gram-positive cocci in clusters. That should make you think of coagulase negative staph, or for example, gram-positive bacilli or gram-positive rods that can be associated with Corynebacterium, Bacillus, Propionibacterium acnes, or Lactobacillus, and others like Micrococcus could be reported initially as gram-positive cocci in pairs. Verdens group Streptococci can be reported as gram-positive cocci in chains. So keep this in mind, because this is what you are going to receive initially in the blood culture report, and then again based on that organism and based on the clinical scenario and other two factors we're going to talk about now, you consider this to be contaminant or not. The third factor is the number of bottles reported as positive. So generally speaking, contaminated blood cultures, they tend to grow in 1 or 2 bottles only. So usually what happens is most of the time one set of blood cultures means 2 bottles, aerobic bottle and anaerobic bottle, so that's considered one set. And then usually what happens is the phlebotomist or the nurse will take about 20 to 30 ml of blood per venipuncture to add to these bottles, and this will result in the 2 bottles for one set. Most of the time, depending on the order of the physician, depending on the clinical scenario, so you might need to order 2 sets of blood cultures, sometimes more, depending on the underlying disease and severity of the infection and all that. So usually with the contaminant blood cultures, out of these 4 bottles, usually it's 1 or 2 bottles that grow. Theoretically, because of the number of bacteria, usually the bacterial burden is not as high as in patients with true bacteremia. So this could also be another clue that this is probably a contaminant and not a true infection. The fourth and probably the last factor is the time to growth or time to positivity. So contaminated blood cultures, they tend to grow slower, again, maybe because of the less bacterial burden, close to 24 hours, sometimes even more. True bacteremia, they usually show up a little bit fairly quicker than contaminated blood cultures, and that's usually within 12 hours or sooner. Now, that's not always 100% correct, but it's really, at least in my experience, I have seen that this pattern is really helpful to determine true bacteremia from contaminated blood cultures. So this is just one example in a patient that I had a few weeks ago. So as you can see here, this blood culture was taken around 9 a.m. in the morning, and then there was no growth after 24 hours. But after that, the results showed growth in aerobic bottle was gram-positive bacilli. So that the growth happened really slow. It showed gram-positive bacilli. As you remember, it also suggests this is probably fake news, and the patient ended up not really showing any features of bacteremia, and the final results confirm that it's a contaminant. On the other hand, for this patient, patient had a blood culture taken around 5 a.m. in the morning, and then on the same day in the evening, within about 12 hours, the patient blood culture came back reported as anaerobic bottle with gram-positive cocci in clusters. Now, as we mentioned before, gram-positive cocci in clusters, yes, could be Staph epidermidis, but also could be MRSA or MSSA, Staph aureus. But because it grew a little bit faster and the patient did have some features of sepsis, we thought it's probably true bacteremia, and it was proven later to be MRSA bacteremia, and the patient had a true bacteremia. I think it was from intravenous catheter, if I remember correctly. So keep that in mind when examining the results of the blood culture. Contaminated blood culture grows slower. True bacteremia usually grow faster. So going back to our case, this 38-year-old diabetic patient with non-arterial cellulitis who had good response clinically within 24 hours of starting antibiotics and no other risk factors or complications, not severely sick. And the blood cultures only grew in one bottle, and it grew close to 24 hours, and it showed gram-positive cocci in clusters. Most likely this is probably contaminant. So in this case, probably it's reasonable to document all these findings and document why you think this is contaminant, and then patient is still appropriate for discharge, and the patient blood cultures were followed after a couple of days later after the patient is discharged, and the report came back as staph coagulate negative staph, probably contaminant. So examining all the 4 features in this case, it's probably this blood culture shouldn't have been ordered at the beginning, because it didn't seem like the patient is having any high risk factors or very severe skin and soft tissue infection or necrotizing fasciitis or ICU level of care. But even with the positive blood cultures, it seemed like patient meets many of the criteria to suggest that it's actually a contaminant. So you need to document that and consider that as a most likely diagnosis, and still discharge the patient if the discharge is appropriate. All right, so in summary, recognizing contaminated blood cultures results is really important because it has a lot of consequences and sequelae, as we talked about. Do not order blood cultures if the yield is shown to be low, especially if there's evidence that it's not indicated to do blood cultures in these clinical scenarios. And we give some examples for that. Examining whether the blood culture results is likely to be true bacteremia or a contaminant is based on generally 4 factors. We talked about the importance of the clinical features of the patient, severity of the illness, and the risk factors associated with the case, and whether the patient had any foreign bodies or devices. Number 2, the identity of the organism, and whether the organism is known to be associated with contaminated blood cultures, or the organism should be considered as a serious organism associated with true bacteremia till proven otherwise. The third factor is the number of positive sets or number of positive bottles. The lower the number, the higher the probability of contaminated blood cultures, but not 100% of cases. And then the time to grow, so the time to positivity, contaminated blood culture usually grow slower than a true bacteremia. And then if you believe that the blood culture results are contaminant, just document your findings, document your reasoning, and consider not repeating blood cultures in these scenarios, because you might end up facing the same problem. If you believe that it's contaminant and you have good clinical reasoning, that's it. I don't suggest that you repeat blood cultures. All right, well, thank you very much. Please, if you have any comments or suggestions, please let me know, and hopefully we'll see you in the next video. Bye-bye.